Thank you for joining us for this MDA Engaged Spinal Muscular Atrophy Symposium. I would next like to introduce our speakers, Stacey Tarrant and Natalie Reash, who will be presenting on crucial care management, focusing specifically on nutrition and supplementation, as well as physical therapy. We will begin with Stacey Tarrant, a clinical nutrition specialist at Boston Children's Hospital in Boston, Massachusetts. She has been providing medical nutrition therapy and nutrition counseling to individuals with spinal muscular atrophy for the past 13 years within Boston Children's Hospital Multidisciplinary SMA Clinic. Her other specialty areas include dietary therapy for children with inborn errors of metabolism, including fatty acid oxidation disorders, and the ketogenic diet for children with intractable epilepsy. For the past 6 years, she has been an active member of the Cure SMA Medical Advisory Council. With that, I will hand it over to you, Stacey, and thank you for being here today.
Thank you. I am assuming I have to reshare my screen?
Yes, that would be great. Thank you.
Okay. And why am I not finding slideshow view? Okay.
Looks great.
Looks good now?
Yeah.
All right. Well, thank you very much for inviting me today to talk to everyone about nutrition for children with SMA. And I do have a lot to cover in the short time that I'll be speaking, so I'm just going to jump right in. So, one of the most common questions that I get asked when I'm first meeting with a family who has a child with SMA is, what is the best diet for a child with SMA? What should my child be eating? And my answer is always, there really is no best diet for a child with SMA. And that's because really every child with SMA is truly unique, and that's true more so now than ever with all of the new therapies available. And of course, the children have different food preferences, they have different eating abilities and challenges, as well as different gastrointestinal challenges. So my recommendation is always to work with a dietitian who's very knowledgeable about the special issues that people with SMA face, and that person can help design a nutrition plan that's specific to your unique child. So why is good nutrition important? It's important, of course, for growth. Good nutrition and good healthful foods are going to help provide energy that's going to help to optimize motor and respiratory function in conjunction with all of these other new therapies that the children are receiving. So good nutrition is an important factor in that equation. Children who are well nourished are much less likely to get sick. And if they do get sick, a well-nourished child is going to recover a lot faster. And finally, good nutrition has a lot to do with digestion. And so, there are a lot of digestive issues that children with SMA face, and a healthful diet is going to help improve digestion and is going to help with those GI symptoms that children might have. But we also, of course, want to remember that children definitely have preferences, and food is a source of enjoyment for them. And so we want to try to mesh the two, where we're providing a nice, helpful diet, but also foods that hopefully the child will enjoy. So good nutrition really is all about balance. I never recommend, eliminating any specific food groups or nutrients or giving excess of any. It's really about including a variety of foods in the diet to achieve balance. And I'm going to go into that a little bit more. So what really is a balanced diet? So the first place that we try to achieve balance is with the calorie intake. So calories are really synonymous with energy. So we are trying to achieve a state where the calories or the energy that the child is taking in is about equal to the calories or energy that they're burning. Now, of course, children need a little bit more calories for growth, but when we can achieve balance with regards to calories, we're going to set that child up to maintain a healthy weight for life. Then we're looking to achieve balance in the nutrients that provide calories. So there are only 3 nutrients that provide calories. Those are protein, fat, and carbohydrate. And a lot of families sometimes worry that their children aren't getting enough protein, but it's actually a lot easier to get protein in than you think. And most of the time, when people say to me that they're worried about their child getting enough protein, when we actually start to look at their diet, we do realize that they are getting in enough. So in general, a child with SMA is going to need somewhere between 1/2 to 1 gram of protein per pound of body weight. And so what foods does protein come from? So most of us think of meats as being high in protein, but there's actually a lot of other foods that contain protein as well. So certainly eggs are almost the perfect source of protein. Dairy products like milk and yogurt contain a lot of protein. We have our meats, chicken and fish, which is what we typically think of as protein-containing foods. And then there's also the vegetarian sources of protein, like beans and nuts. And believe it or not, even foods that we think of as carb, like breads and cereals and pastas, those actually contain some protein as well. And even vegetables contain a little bit of protein. So when you start adding up all those sources in a child's diet, most of the time they're getting enough. The next nutrient that provides calories is fat, and especially in a child with SMA's diet, we're looking to provide the essential fatty acids because they are called essential fatty acids because they must be obtained from the diet. Our body is not able to make those fatty acids by themselves. We generally recommend calories from fat to be about 20 to 35%, and this is for kids over the age of 2. Fat content for kids, for children, infants, toddlers under the age of 2 is actually going to be higher. And sometimes people are surprised to find out that actually breast milk has about 50 to 55% of calories from fat. And that's because during that time between the age of birth and 2, that's the most important time for brain development, and fat is really essential in brain development. So what are healthy sources of fat? So to provide the essential fatty acids like omega-3, the sources are going to be, fatty fishes like salmon, mackerel, whitefish. And I know a lot of people may have trouble getting their kids to eat those kinds of things. But another great source of the essential fatty acids are going to be plant oils like walnut, canola, flaxseed oil. And the nice thing about oils is sometimes you can sneak them into foods without anyone even realizing that they're there. Avocado is also a very healthy source of fat, although it's not really a source of the essential fatty acids. And then the remainder of the diet is going to come from carbohydrate, usually about 50 to 60% of calories. And with carbohydrates, we're really favoring choosing complex carbohydrate over high sugar processed foods. So carbohydrates coming from whole grains, like whole grain breads, cereals, pastas, beans and legumes, which you might notice they're also in the protein category, but they're also a nice complex carbohydrate that has a lot of fiber that can help with digestive issues. And fruits and vegetables. Some people, it's funny that people don't even think of fruits and vegetables necessarily as carbs, but they're also very healthy sources of carb because they're loaded with fiber and they're loaded with vitamins and minerals. And so those are the kinds of foods we want most of the carb sources coming from. We're also looking to achieve balance in the diet from nutrients that don't provide calories. So Vitamins and minerals are included in healthful sources of foods that we eat. And the fact that, this slide has lots of color, all the color isn't there to really make the slide look pretty. It's really to sort of emphasize that a child's plate should have some color on it, because the foods rich in color are the ones that are going to be rich in vitamins and minerals. And so if your child's plate has a lot of white on it, like, chicken is white and it's fine, that's a protein source, but if the rest of the plate has like French fries or just pasta or something like that, and there's nothing green or red or yellow on the plate, then it might be that your child is not getting vitamins and minerals that they need. The other thing I want to say about vitamins and minerals, I do say that food is the best source. People often will ask me, is there a vitamin and mineral supplement that my child can take that will help them gain weight? And the answer to that is no. Because supplements don't have any calories, they're not going to help with weight gain. You really need calories to gain weight. And getting in your calories with foods that are rich in vitamins and minerals are sort of the best way to do it. A mineral and a vitamin that we pay particular attention to for children with SMA are calcium and vitamin D, because these are very, very important for bone health. And you see on this chart the recommendations by age for how much calcium and how much vitamin D a child should be getting in their diet. And these are, really, especially with the vitamin D, minimum levels. The thing about calcium is that there is a blood test for calcium, but it doesn't really tell us or give us an indication whether your child is getting enough calcium in their diet, because your body wants to regulate that blood level of calcium so tightly that it will actually leach calcium out of your bones to maintain a blood level in the normal range. So the only way to know whether your child is getting enough calcium or not is through a bone density scan, which is it's a much more involved test. It's not done all the time. So we just try to meet the DRI for calcium. With regards to vitamin D, there is a blood test that we can check the level, and it is very indicative of whether the child is getting enough vitamin D. So the amount that we might recommend might be higher than these levels that you see on this chart if the child's level is low at baseline. You can, of course, and we recommend trying to get your calcium and vitamin D from food if possible. For children, depending on their age, we're aiming somewhere for between 2 to 4 servings of calcium and vitamin D rich foods per day. So what food sources contain calcium? So of course, the dairy products like milk, yogurt, and cheese, those are going to be the highest and most absorbable forms of calcium. There are also foods fortified with calcium, like fortified orange juice, if that's specified on the carton. And then some other foods that do contain calcium are things like broccoli and dark leafy green vegetables. Although among my population of children, most of them will not eat enough of those kinds of foods to really make a difference in their calcium intake. So if they're not getting in a lot of dairy products, I may recommend supplements at that point. With regards to food sources of vitamin D, because D and calcium are bone nutrients that kind of worked in tandem for healthy bones, most of the milk out there that's commercially sold is fortified with vitamin D. You may also have yogurt fortified with vitamin D, as well as orange juice and cereals. And then that same kind of fish, the fatty fish that's essential for the essential fatty acid intake, are also rich sources of vitamin D. So, we try to do it with food. If we can't get it in with food, we will add supplementation. Another really important aspect of nutrition for children with SMA is getting in adequate fluid. So the amount of fluid that a child with SMA needs is really going to depend on their body weight and their health status. So typically for children, about 1.5 ounces or so per body weight is usually enough. However, if the child is sick or if they're having increased secretions where they're losing more fluid, and in the setting of sweating, the same kind of thing, they may need more fluid. We typically recommend water and flavored waters as the best source of fluid because we're not looking to provide a lot of extra calories with their fluid intake. And that's why we tend to tell people to take it easy on the juice, really recommending less than 1 cup of 100% fruit juice a day. And even if it's, all natural fruit juice, and even if it's 100% organic, the body still treats it as a source of sugar. And it is really empty calories that don't help to make the child feel full. Same as things like soda, juice drinks, and other sugar-sweetened beverages. And then one other thing that I always kind of alert parents to, and they probably know this themselves, but we see underhydration a lot in children who go to school. And this is typically because children who go to school absolutely do not want to use the bathroom at school. And they often need assistance to do so. So children tend to not want to drink a lot at school. So if that's true of your child, you may have to make up for their fluid intake when they get home. Okay, so most of what I was just talking about was a little bit more focused on children who eat by mouth. And so now I'm going to switch over and talk a little bit about tube feeding and achieving a balanced diet there. So despite the new therapies and how much better children with SMA are doing now, they still can have some feeding and swallowing problems. Unfortunately, the swallow muscles sometimes are one of the first muscles that children lose weakness in. And even with the therapies and after therapy, if they've already lost some swallowing function, the swallow function is kind of one of the last things to start to improve. So when children have weak swallow muscles, they are at risk for aspiration, which means, the food or formula is going down the pipe the wrong way, is what we always say, but it's going into the lungs rather down the esophagus and into the stomach. So how do you know if your child might need a swallow evaluation? Well, any child with SMA who presented with SMA symptoms in infancy, we're usually recommending a swallow study as soon as possible. And then, if they are treated with new therapies, periodically repeating those swallow studies to see if there is improvement before thinking about introducing any food by mouth. Another indication might be if the child has symptoms of aspiration, like coughing or choking when they're eating. They get tired quickly. They're not able to finish a meal. They're frequently sick with pneumonia, or maybe it takes them a long time to eat, or they're a little bit reluctant to swallow. So they're holding food in their mouth and they're not wanting to actually swallow it. And then another indication might be, a child who starts to have difficulty gaining weight or perhaps loses some weight. So the good news is that even if your child needs a feeding tube, it doesn't mean that they're not going to be able to eat at all. It just might mean that they can't meet all of their needs, whether it's food or fluid or both, taking it orally. So we have some children who have a tube that's used just for medications and fluid administration only. We have some who might just have their tube there and use it when they're sick, or maybe at the end of the day they're too tired to eat, or they may have a particular day when they're not eating well. Some people will do overnight tube feedings with all oral feedings during the day, although I have to tell you that I'm not a huge fan of overnight tube feeding, just because I think physiologically we're not really meant to eat overnight, and that's the time when our body needs the least calories, because we're really at rest during that time. So a lot of children that I have who are on overnight tube feeding, sometimes I try to work with the families to get them off of the overnight so that they can get most of their feeds during the day. Some people might use the tube as a meal supplement during the day, so maybe having oral meals, and then if they're not able to eat a lot at the mealtime, maybe topping off the meal after the oral feeding with a little bit of tube feeding to provide the extra calories that they need. And then, of course, there are some children who are not able to swallow at all safely, and so they may need tube feeding to provide most or all of their nutrition. And we can do this actually in a variety of ways. I am finding that children who have received a lot of the new therapies and are much stronger are able now to tolerate sometimes boluses by syringe. So where you're just pushing or allowing feeding to go through a syringe by gravity. So they're not hooked up to a pump for an extended period of time. We can also do boluses by pump over an hour or 2 hours or whatever your child's able to tolerate. And then I would say in very rare instances now are we requiring, or is a child needing continuous feeds over 24 hours, especially a child who's been treated with new therapies. The good news also is that the formula companies are finally getting the message that people do not want to feed their child through a tube foods or formulas where they look at the ingredients and maybe the only ingredient they recognize is sugar. So many of the companies now are coming out with real food tube feeding options, which sort of mimic like if you were taking food at home and putting it in a blender and then feeding it to your child through the tube. That's what these kinds of foods or formulas are designed to do. So, you know, they have lots of different protein sources. Some have chicken as the protein source. Some are vegan. Some are vegetarian. Some have soy protein, and then we have organic formulas as well. So there's so many different choices now. And I would tell you that most of the patients that I follow with SMA who are tube fed are actually probably on one of these formulas. I have very few kids on the old-fashioned formulas. And the great things about these formulas too is that they also, because they are real food, they help a lot with GI symptoms. All right, so that's a good segue into managing GI symptoms. So a lot of children with SMA, of course, do suffer with constipation and or poor motility. There are some dietary solutions that we can recommend. So one of the first things I always check is to make sure that the child is getting enough fluid. If they're not getting enough fluid, increasing that. And sometimes that's all the child needs to actually help resolve some of the constipation that they're having. Including more fruits and vegetables and whole grains in the diet whenever possible. And I do get it that there's a lot of really picky eaters out there, and sometimes that's really hard to do. But, you know, even we try to take small steps, baby steps toward improving the quality of a child's diet to help work on the constipation in that way. Sometimes a little bit of juice, like apple, pear, white grape, or prune juice can help. I've often recommended prune juice in infants with tubes who have constipation, and sometimes a little bit of that, maybe once or twice a day, also does the trick. There are some families who swear to me that probiotics are all their child needs for their constipation, but I will caution you with regards to probiotics that They all have different strains of bacteria. And because a child's gut bacteria, not everyone's gut bacteria is the same. And so one probiotic that might work for one child might not also work for another child. So if you try a probiotic for constipation and it's not working for your child, then you might try a different one and you may have a completely different experience. And then, you know, if all of these dietary solutions don't work, then your child may need a daily medication for constipation or GI motility. And I will also say that, you know, if your child has acute constipation, like they've been backed up for 3, 4, or more days, that is not the time to try to start treating that constipation with diet. In those backup situations, a medication for constipation is really going to be necessary. Okay, some children with SMA also suffer from gastroesophageal reflux or GERD. So we have some dietary recommendations for that as well. So sometimes if your child's diet is very high in fat, then you might want to decrease the fat a bit. Fat is the slowest digested nutrient. It stays in the stomach the longest and therefore is more likely to come up. Also, you know, people who suffer from GERD can have different food triggers. So keeping a food diary with the symptoms of GERD to see if you can determine what your child's triggers are, and if so, then having them avoid those foods. Eating the last meal about 3 to 4 hours before bed, because certainly if you're eating close to bed and then you go and you lie down flat, that's a trigger for gastroesophageal reflux. And so after eating, you want to keep your child elevated as much as possible. And if you are doing tube feeding at night when the child is sleeping, then trying to elevate maybe the head of their bed to at least a halfway sitting position is going to help alleviate some of those symptoms. And then when your child is tube fed, potentially providing smaller feeding volumes more often and or slowing down the tube feeding rate. And again, if none of those dietary interventions work, then also the child may need a medication for the reflux. Okay, and then finally, I also wanted to address the issue of how long can a child with SMA go without eating. I know that there is a lot of information online and among the family groups about how long a child can safely go fasting without being fed at all. And I tend to, when I hear from parents what they're hearing about online, the fasting times that they're hearing about are actually a lot more conservative in this day and age of SMA. So when a child is well, how long they can go without eating is really going to depend on their overall health and nutrition status. So a child who's better nourished is going to be able to go longer without eating than a child who is very, very thin. So with regards to the type of SMA and severity of SMA, so non-sitters, what we used to classify as type 1 SMA, can typically fast for about 6 to 8 hours when they're well. Sitters, or what we previously classified as type 2 SMA, can typically go for about 10 to 16 hours without eating. And in general, under most circumstances, there really is no need to wake a child overnight to feed them or to do an overnight tube feeding for a child who's over the age of 1. Now, if the child is sick, those recommendations are going to change a bit. So we definitely are recommending decreasing the fasting times if the child is sick, But again, as I mentioned, the stronger and better nourished that a child is, the longer that they're going to be able to fast. And in any event, when your child is sick, of course, you want to keep in close contact with your medical care team for recommendations with regards to that. So, in summary, we're trying to achieve a balanced diet by making sure that calorie intake is meeting energy needs, not exceeding energy needs, and not being below what their energy needs are. You want to include all nutrients in the diet, so protein, fat, and carb sources that are going to provide vitamins and minerals. And then if there's some reason why there are particular vitamins and minerals that we can't get in the child's diet through food, then adding supplements as needed. I really caution you against going with extreme diets that either severely restrict or provide excessive amounts of one or more nutrients. You want to make sure you're providing adequate fluid and preferably fluid without calories, with the exception of milk and dairy products. And then you're going to manage the GI symptoms with diet if possible, or with medication if necessary. And of course, maintaining communication with your medical team during illness. So I thank you for your time, and now I'll turn it over to the next speaker.
What a wonderful presentation. Thank you
you
for sharing your knowledge on different nutritional aspects, Stacey. I really appreciate it. Please note that we will continue with Q&A after our next presentation on physical therapy aspects within care management, so please stay tuned. But in the meantime, please feel free to chat in any of those questions you may have for that Q&A session. I will now introduce you to Natalie Reash, DPT, is a neuromuscular physical therapist at Nationwide Children's Hospital in Columbus, Ohio. Clinically, she works in the multidisciplinary neuromuscular and SMA clinics. She also has a role in research within the Lowe's lab at the Center for Gene Therapy. Her interests are focused on improving clinical trial readiness, outcome measure development, and defining the natural history of neuromuscular disorders to inform clinical care and upcoming clinical trials. She is a member of the international training team that serves as the gold standard for clinical evaluator training and reliability in neuromuscular disease clinical trials. With that, I will hand it over to you, Natalie. Thank you so much for being here.
Thanks for having me. So let me get my slides up. All right, and is that the right thing showing, I think? Okay.
It is, yes.
So again, thanks for inviting me to talk. And like we just said, I'm a physical therapist, so I'll be going over physical therapy recommendations in this new and exciting era where we have treatments for spinal muscular atrophy. Okay, so one of the main questions that we get as physical therapists is, okay, we have these new treatments available. Now what does that mean as far as physical therapy and gross motor skills? And so it's an exciting time, and the reality is we don't know yet. We don't know all the possibilities that there are, so we're just going step by step. What we do know as physical therapists is that development is a sequence, and so one skill builds off another. And so your physical therapist and you at home can work with your child to gain strength to progress toward a new milestone, and then we need a lot of practice for any new milestone, and then once they achieve that milestone, then we get to kind of start the cycle over and think about what the next thing we should be working on. One of the things we like to talk about a lot is that even though we have all these exciting treatments, it doesn't necessarily mean that it's a cure. So the gold standard is, of course, that you maintain the multidisciplinary care approach. And so this graphic, we really like, it was taken from the most up-to-date clinical care guidelines. So the patient and the family are in the center of this model, but you can see all of these specialists and disciplines are supporting you and your child with SMA to provide best level of care and achieve the best outcomes. And so, as you know, the care team consists of pulmonologists, acute care, neuromuscular rehab, orthopedics, nutrition, therapy like physical therapy, occupational therapy, social work, all kinds of things. But we're all working together with you and your child to provide best care and individualized for your unique needs and your child's unique needs. So in that care model, the role of physical therapist is really, to put it simply, to maximize independence. So the goals of therapy include to maximize your child's abilities and achieve tasks that are important to your child and your family. We hope to improve their mobility and their independence so that they can become more engaged in daily living and in the community, and overall enhance quality of life. And so these recommendations and physical therapy interventions are of course tailored to the child's age and abilities. So we'll kind of go through them based on the new classification, like Stacey mentioned. We used to say SMA type 1, type 2, or type 3, but now in this new era of treatment, since we are seeing patients move from across categories, sometimes we are classifying them as their current highest level of motor independence, so non-sitters, sitters, and then those that are able to walk or that are ambulant. So here we have kind of an overall view of physical therapy assessment, intervention, and considerations for non-sitters. So if you see a physical therapist, they're going to be looking at a lot of the things listed under the assessment column, including postural controls, scoliosis, contractures, looking at range of motion, muscle weakness, sitting tolerance, but also keeping in mind other things like hip dislocation that may be present, chest deformities that may be present. And so depending on you and your child's goals and their abilities, the physical therapist that you're working with may use sort of these interventions such as positioning and bracing, some prolonged stretching, and that could be through positioning or it could be bracing, and then also activities that promote function and mobility. So for non-sitters, we really think about using like switch toys and lightweight rattles, bath equipments, environmental controls and eye tracking devices, different equipment such as strollers with the ability to recline and lay back. They may use standers if it's possible to do some more upright function, and a TLSO, so one of those chest braces may be used, but most of our non-sitters require the abdominal cutout so that breathing isn't impacted. And so we use TLSOs as a way to support the abdomen so that the child can focus more on their upper extremities during certain tasks, rather than necessarily to reduce scoliosis. And so families and therapists can get really creative. And so we've seen some really cool things. So one of the things that therapists like to recommend for non-sitters as possible is just doing different activities in different positions. So in supine or laying on their back, we might recommend using wedges to be partially upright. We could switch the side that toys or the TV are on periodically if possible. And also it's possible to practice keeping head in the middle if that's safe for your child. But again, you may need rolls or pillows and increased suctioning because it is more difficult to keep your head in the middle. Sidelying is a great position for our non-sitters. They can practice with the head in the middle like I was just talking about. And because gravity is working on our muscles in different ways in Sidelying, we see that the kids are often able to do more arm and leg movement in these gravity eliminated planes. So you can see from the picture below, we've had some creative families and therapists that have built little like arm swing slings from PVC pipe. So this young girl has her forearm in this sling that's made by a PVC activity mat. So then she's able to color independently and have some fun while she's doing some physical therapy. And then another position, if possible, is prone. Use of a wedge can help increase the tolerance because, as we know, like being completely flat is much more difficult than being partially flat. You can have your child over your legs if that's easier, but it is important to remember that being prone makes it harder to use your belly muscles for breathing. So oftentimes this may not be possible, or if it is possible, we may not be there very long because we don't want to restrict those muscles that are needed for breathing. One thing we always like to touch on when we talk about kind of physical therapy in our non-sitters is passenger safety. So it's recommended for most non-sitters that they use a car bed as a form of car seat. So, but now that we're seeing patients being able to transition to the more like the rear-facing, more upright car seat with treatments and all sorts of gaining new motor skills, we want to make sure that it's safe to do so. So at Nationwide Children's, we started doing a modified NICU car seat test protocol if we have a child that we think it may be safe to start thinking about transitioning from a car bed to, like I said, the more upright. And so what we do is we have the family bring in the car seat that they want to use, and we have the child hooked up to like a pulse ox monitor, and we have them sit in the car seat the length of time that's equal to the time to travel home, or 90 minutes. And it's important to remember that any supportive care that the child needs during the car seat test, so like if they need suctioning or if they need a parent to like help position them again, so anything that is needed, any supportive care that's needed during the car seat test must be available at all times during travel. So that means if a second person is needed in the back seat in order to provide some of those interventions, then you have to make sure that a second person is always available in the back seat before transitioning to this other car seat. So we have certified passenger safety technicians at our hospital. And so if you haven't met with one and you have questions about passenger safety, I'd highly recommend next time going to your hospital or clinic, asking those questions and seeing if your hospital may have a similar program. Let's see. Okay, and so then moving on to specific physical therapy recommendations for sitters. Some of them are the same, like the assessments you'll see. The assessment column sometimes looks similar, but the interventions and care considerations shift a little bit. So for sitters, we again might be thinking about positioning, embracing, and prolonged stretching and promoting function and mobility, but we may target this a little differently. So your therapist may recommend night splints for a prolonged stretch, if appropriate. They may recommend a supported standing program. Swimming, horseback riding, or hippotherapy and wheelchair sports may be something that's a great way for your child to be active and participate in their community. And then also we can think about custom seating based on the individual's needs, like power wheelchairs with different features such as tilt and recline, seat elevator, leg rest elevator, or depending on your child, they may be most appropriate for like a lightweight manual chair or a power assist. So just talking with your therapist, whether that's physical therapy or occupational therapy in your local area, about what sort of things they would recommend for your child is a really good idea. And so here I have some pictures of positioning and embracing ideas. So again, like the TLSO could support our sitters. And so again, we usually recommend it more of like letting them, it provides support at their trunk and core muscles so that they can focus on tasks with their arms, or maybe even at school, if they're fatigued at the end of the day, maybe they wear the TLSO when they're going to be doing like a lot of upright activities that use their arms a lot. But again, not really for the use of preventing or slowing scoliosis, but more of a part-time support when they want to focus on upper extremity strengthening tasks. Orthoses may be recommended for positioning or standing. So if your child is using a stander or has orthoses like this child, like an HKFO, those may be helpful to give them extra support so that they can focus on practicing standing. And so that can be beneficial for multiple systems in the body when able. And so being upright and doing like upright standing can help with bone density, it can help with digestion, just social interaction. So all of these things are good to think about and work into your routine and your child's therapy plan with your therapist. So this is a creative solution for our sitters. So we did a study at Nationwide Children's led by Megan Marino, who's one of the physical therapists on our team, where we wanted to see if in-home bodyweight support systems would work for our kids with SMA who were treated and who could sit with good head control but weren't able to stand or walk independently. And so it's a unique treatment modality that it looks like a 10 by 10 like pop-up tailgate tent almost. And so you can see in this family's home, you can go around your furniture like a couch or a coffee table or child's bedroom, whatever room works best. But it offers 360 degrees of near frictionless mobility within the frame. And so it can fit easily in your home, and it allows the child to move in all three planes. And so it has the option to do adjustable body weight support so that you can provide like just the right amount of challenge. So you can see this young child has the bungee support. So he, like I said, he could sit, but he isn't able to stand. And so this allows him to practice putting weight through his legs and also work on building strength in that manner. This is the website for this particular model. I think there are other models, but this is, we often get asked about which particular one we used. So this is the website for the company that sells them. And so, like I said, we did a study and we wanted to see, did it help improve like motor milestones, and also what was the family's experience. So 24 of the kids that were in the study, or 92%, had improved motor skills. And we, like I said, one of the requirements for the study is that they are treated. So we, of course, expected them to gain skills anyway because they were treated with these new and exciting therapies. But when we did the statistical analysis, the main factor of how much they improved, when we took into account time since treatment and that sort of thing, the main contributor to amount of improvement was how often they used it. So like I said earlier, like development is it builds off one another. And so to gain a new skill, we need a ton of practice. And so this allows kids to practice working these muscles that are harder to practice without something like this. And so 20 of the families, or 77%, saw improvement in non-motor skills. And none of the families said it was difficult to use, and 92% said it was a beneficial experience. And so some of the other family reported benefits was that their child had an increased independence in play, they could help build their confidence, and they could have more of a dynamic interaction with siblings or parents. So like you can see, this mom is coloring with her child while he practices getting some weight bearing versus, if you're having to support your child, you don't have a free set of hands to then play also. So like I said, overall, it's more than just motor. So we're able to achieve dynamic weight bearing, activity dependent learning, other system benefits, and just a greater amount of activity or exercise than we're often able to achieve without something like this. So the study that we were doing at Nationwide is currently closed. We're not enrolling. And Megan, like I said, on our team that was the leader for this study, is she's working on the manuscript. So hopefully those results will be published and available soon. All right, and so then transitioning over to our walkers. Again, the therapist the goals are to promote function and mobility. And so we may do this from a wide variety of ways. So aerobic and general conditioning exercise. And this may be just depending on what you and your child have available and what they also enjoy. So swimming, walking, biking, yoga, hippotherapy, all of these things are great options. It just kind of depends on the child and family. Some general recommendations are its optimal duration for aerobic exercise is at least 30 minutes a day. And we also want to make sure that we're including balance exercises. And for our walkers, bracing and stretching may be needed based on the individual. So again, like your therapist may recommend night splints. They may recommend some ankle orthoses if needed to maximize function. And again, the thoracic bracing may be used to promote posture and sitting, but all of this really depends on your child's unique needs. And so then just a couple notes to wrap up so that we have some time for questions at the end is one of our favorite activities if across all abilities and ages is any activity in the water. So it's a great way to get aerobic exercise. We can work muscles differently than we can on land. The water itself serves as resistance, and the therapist or you can add other things like flippers and different things like that to make activities more challenging or to do some targeted strengthening. Oftentimes playing in the water feels more fun than exercising on the land. And again, so it doesn't have to be aquatic physical therapy, because I know sometimes that's limited to more city areas or versus rural, depending on where you live, and depending on insurance. So aquatic therapy is great, but if that's not available, then you could also have your child participate in swimming lessons or just playing with you at a community pool. So any activity in the water is one of our favorite activities to recommend for our kids with SMA. And then all of this to say is that it's a balancing act. So we have all these recommendations for physical therapy and all the other disciplines that I know you're hearing about today, but the child and family's goals are the most important. And so we know that in real life, it's impossible to do everything all at once. So maybe PT isn't the priority for you and your child right now, but it will be at a different time. Or maybe it is, but your PT and your care team can help. So I think just having that conversation and open communication with your therapist and care team in general is great, because we understand, like, we have all these recommendations, but we know that real life happens too. So we want to make sure that we're supporting you and helping you achieve your goals. And like we said, those goals are very likely will shift across the age of your child and your family. So with that, I have a question slide, but I think we'll probably open it back up to more general questions. So I can stop sharing. Is that right, Mallory?
Yes, that's great. Thank you very much, Natalie. I really enjoyed the multidisciplinary care model that you shared and learning about those unique interventions tailored to different abilities. And it was also really neat just to see families often getting creative to support different positioning and mobility needs. But as you mentioned, we will move into our Q&A session. It looks like we do have plenty of time to hopefully address everyone's questions. So please feel free to add in any questions regarding nutrition as well as physical therapy for our speakers. Feel free to utilize the Q&A button at the bottom of your screens, and we welcome any questions. All right, so we kind of have a long question here that I have not had a chance to read over. So my G-tube fed type 1 treated is on one of the formulas you showed in your presentation. We mix the formula with fresh fruits and veggies we puree at home and blend all together along with other fluids and grains. Do you recommend that we switch up the pre-made formula every so often, or is that not necessary?
So I think it's difficult to switch up the pre-made formula because typically, you're getting a prescription for it, you're submitting it through your insurance, and so you can't be switching the formula all the time. But I think it's great that you're adding additional things to it. I don't think that that's a bad thing. So you are in effect kind of switching in. If you're adding fruits and vegetables, and presuming that you're adding in different things, then you are adding more variety into the diet. So I think that's a great solution. Did that answer the whole question, or was there another part?
I think it did, but
Okay.
there is another part. So he
Okay.
is currently vegan and has been for years,
Oh.
and they're interested in introducing some meats to the diet and are wondering if you have any suggestions on how to introduce this safely without risking, additional GI issues and disruptions.
Yep. And I think that, if the child is 100% tube fed and you are adding additional things into the formula, you could certainly puree meats, but I would caution that you have to, when you're pureeing meats, you have to have a really, really strong blender. So we generally recommend something like a Vitamix or a Blendtec blender or something, because the last thing you want is for the tube to get clogged. I think things like chicken and fish, Fish is actually a good one to introduce because it's kind of softer and probably would blend up a little bit easier than like chicken or a red meat.
Great. Thank you so much for that information. Thank you so much again for joining us today, Stacey and Natalie. We appreciate you sharing your presentations on care management and appreciate you being with us today.